Welcome to the 2020 Public Health Law Virtual Summit. We have two presentations in this session, and each individual presentation will be followed by its own Q&A. Use the chat feature to submit your question. If you encounter technical difficulties during the summit, go to the navigation menu and select the Need Help button. I will now turn it over to Ross Silverman, our first speaker.
Thank you very much. It's a pleasure to be here today. And I will be getting everything up and running here. I want to appreciate all of you who are attending. Thank you very much for being here today, for selecting this session. I want to thank the network for holding this summit and also for inviting me to participate both in the Policy Playbook project and in this session today. I'm the first of two speakers, and I'll be talking about contact tracing, intrastate and interstate quarantine, and isolation. First, as far as the introductory materials are concerned, this is based upon the section that I wrote, the chapter 3 in the Public Health Watch Policy Playbook. I have no conflicts to report. All the views that I offer in this session are my own, and like many of the speakers that you're going to hear from today, I am a lawyer, but I'm not your lawyer. So anything that I say today is based in educational value only, should not be relied upon as legal advice. The issue of testing and contact tracing and quarantine of those who are deemed to have come in close contact with infected people, as well as the isolation of those who test positive, comprise a systemic response to slow the transmission of an infectious disease like COVID-19. There are no effective, widely available treatments, nor a vaccine, so this has become a principal approach to containing the outbreak. Case investigation and contact tracing are defined by the CDC as fundamental activities that involve working with a patient, symptomatic and asymptomatic, who has been diagnosed with an infectious disease to identify and provide support to people, the contacts, who may have been infected through exposure to a patient. While grounded in the law in fundamental police power authority, the efforts to use contact tracing as well as quarantine and isolation are subject to judicial scrutiny as they infringe upon fundamental constitutionally protected rights, including privacy, freedom of travel, equal protection, and due process. These measures have been used in past, more limited infectious disease outbreaks in the United States with some success. However, the nature and spread of COVID-19 and the costs of creating, implementing, and sustaining a disease control and social support infrastructure that's effective, just, and grounded in equity are daunting. The history of effective use of state and local contact tracing and quarantine and isolation measures to address infectious disease outbreaks date back to before the establishment of the United States. This process has been used successfully in numerous infection control programs, including tuberculosis, smallpox, as seen in the poster on your screen from the 1970s Ethiopian smallpox eradication campaign, HIV and other sexually transmitted infections, measles, SARS, and Ebola. This type of shoe leather epidemiology by disease detectives is also key to surveillance efforts aimed at understanding the spread of the infectious disease. Contact tracing itself, just very briefly, helps slow the spread of an infectious disease in a community through the following process. First and foremost is the test, and once a test comes back positive that the person has been infected with the virus, a trained member of a contact tracing program, the contact tracer, will get in touch with individuals who are newly diagnosed with the infection. They educate them about the disease, and they request that the individual, the patient in this case, stop interacting with others during their period of infectiousness. Second stage is through interviewing the infected person. They will seek to identify recent close contacts. The contact tracer then will communicate with those close contacts, inform them that they likely have been exposed to the infection, encourage them to seek out testing and to stop interacting with others until they themselves receive test results indicating they are not infected, or until the period of infectiousness has ended, which is for this particular virus 14 days from their last exposure. In addition, ideally, contact tracers are going to work to connect those that they contact with healthcare, social services, and other resources that may help the contacted person to overcome obstacles to testing, treatment, and completion of their period of quarantine or isolation. When case counts in a particular geographic area are low, the contact tracing efforts can help suppress the spread of the disease. Contact tracing also serves as part of mitigation strategies. To quote Dr. Adrian Gardner, in some ways, contact tracing is a last line of defense. It's trying to take fires or cases and prevent them from becoming forest fires or outbreaks. By identifying contacts of those identified as carrying the virus and helping those identified contacts get tested and to quarantine, the tracing process can help reduce community transmission and spread, keeping symptomatic case counts down to a level within local healthcare capacity. Furthermore, in order to work, such efforts do not need to be perfect, identifying every symptomatic patient and every contact of every patient. Nor should contact tracing be abandoned during times of widespread virus transmission. Under such circumstances, contact tracing can be highly effective if these efforts are focused on cluster breaking, identifying circumstances where virus transmission has occurred en masse, such as large gatherings, nursing homes, processing plants, dormitories, cruise ships, jails, and prisons. There are a few barriers legally to the contact tracing process. This is a fundamental responsibility of the state under its police power to protect the health, welfare, and safety of its citizens. Infectious disease surveillance, investigation, and control are core public health agency duties that have been delegated to the executive agency at the state and at the local level. And furthermore, emergency response laws have enhanced the authority of respondents and the purchasing powers of agencies in order to adequately respond to the COVID-19 outbreak. And there are also privacy and confidentiality issues, but the protections are largely in place because, like other surveillance for public health and other infectious disease data, this information is covered under infectious disease control laws that are already available in the state. The one notable legislative action concerning contact tracing beyond funding efforts took place in June 2020 in Kansas, when they passed their COVID-19 Contact Tracing Privacy Act during an emergency legislative session. Several provisions make explicit best practices for contact tracing, including establishing expectations for hiring qualified contact tracers, privacy protections over information that is collected and handled during the contact tracing process. Other provisions significantly favor individual privacy over the benefits that might come from using private information to advance broader public health efforts. The law prohibits the use of cell phone location data for contact tracing purposes. It also establishes that third parties may not, quote, be required to collect or maintain data regarding infected persons or contacts for the purpose of contact tracing, thereby prohibiting public health agencies from requiring things like businesses, schools, restaurants from tracking COVID-19 status of employees or students or patrons. Finally, the law also establishes the participation in contact tracing is voluntary, and that neither contacts nor those with new diagnoses may be compelled to participate in the contact tracing process. It's unclear whether these provisions are going to foster greater public trust and participation in the contact tracing efforts, or reduce any stigma that they may be associated with, a positive COVID-19 diagnosis. Alternatively, it's also unclear whether by raising these as concerns, the Kansas law may foment increased skepticism and reluctance to collaborate with public health. How effective and efficient contact tracing will be is affected by the characteristics of the infection, the availability of timely testing, and the contact tracing agency's capacity to handle the area case volume. Each positive diagnosis may result in numerous close contacts that then may require rapid follow-up. Because the COVID-19 spreads easily and asymptomatically, any contact tracing associated with this virus must occur extremely rapidly or risk becoming ineffective. The longer the delay, the greater the number of potential exposures and new cases, who in turn create their own networks of potential exposures and new cases. So how's it going? Not great. Implementation and legal issues have arisen related to contact tracing during this entire epidemic. What we have here are a couple of recent headlines that really kind of dot the I as far as the judgment on how contact tracing has been going in the United States. Our slow response and lack of testing from the beginning of the outbreak meant that COVID-19 rapidly became widespread. Local capacity was then overwhelmed, leading the federal government, state, and local health departments to then begin hiring, training, and deploying additional contact tracers, or contracting with outside companies and agencies to try to provide area contact tracing services. A lack of national coordination, health messaging, and adequate fiscal support have exacerbated what's become a patchwork response effort at the state, county, municipal, and university levels with tight programmatic budgets. And then there's the conspiracy theories on top of all of that. Contact tracing presents significant implementation challenges for most state and local health departments, which have suffered devastating budget and personnel cuts over the past 15 years, including the elimination of 50,000 public health positions in the 2008 recession alone. Local public health efforts that may have been involved in other health-related responsibilities have been shifting to cover contact tracing and COVID-19 related issues, which means that other types of community benefits that can come from public health engagement have been put to the side. These ramp-ups that have occurred by the state, local, and university systems, they are, as I mentioned, they don't tend to be extremely tightly coordinated, and they are still very much underpowered in much of the United States. Many states and communities have chosen to rely on engaging with close contacts through telephone call centers rather than through face-to-face interviews. This may reduce outreach-related time and travel costs and increases the safety of contact tracers, but such an approach can adversely affect public trust and participation in the contact tracing efforts, as contact tracers oftentimes are going to be more anonymous and they may be mistaken for telemarketers. Best practice standards recommend that to maximize trust, those hired as contact tracers come from the communities they will serve. This may not always occur with contact tracing operations that are centralized as opposed to run by the local public health department, or that use a national pool of employees. Furthermore, the size and scale of the outbreak have led to recommendations that human contact tracing efforts be supplemented with digital contact tracing applications, which Professor Oliva will talk a little bit about in a few minutes. Johns Hopkins Center for Health Security estimates an effective response nationally would require about 100,000 contact tracers to adding them to the existing public health workforce. This map that we have on the screen here is from the Fitzhugh Mullen Health Workforce Institute and their contact tracing workforce estimator. What you can see here is that in most places around the United States, in order to adequately respond to the contact tracing need, most states seem to be significantly underpowered. And this circumstance is leading us not only to have an unchecked spread of COVID-19, but also the disease control processes that we're going to have to rely upon in order to try to contain the virus are going to be even more blunt, like introduction of community stay-at-home measures or business and school closures or reclosures. So one of the nice things is that last week, the brand new version of the 10 Essential Public Health Services came out, and a great component of that is that it centers in the middle of all public health services, of the essential services, equity at the core. Contact tracing itself is more than a surveillance and infectious disease control mechanism. Building a contact tracing workforce can result in the hiring of many workers who may have lost other means of support during the pandemic. When contact tracing programs are rooted in values like human rights and dignity, due process, community engagement, those hired as contact tracers will be drawn from and reflect the cultures within and speak the language of the local communities they serve. Building public health literacy and trust in the public health response efforts. When implementing contact tracing initiatives, public officials and public health agencies should be supplementing frontline disease management with public education campaigns about local contact tracing processes, the need for public cooperation, and how all this collaboration will aid in COVID-19 response. So another component of this, as the CDC notes, is that part of the process of supporting patients with suspected or confirmed infection should be a core part of COVID-19 contact tracing as well. It should include facilitating rapid access to care, easing burdens related to quarantine and isolation. This may include basics like food, laundry, housing assistance, or hotel-based services for those who are unhoused, childcare or dependent care services, connection with health insurance or other treatment services, as well as access to income supports, ways to get protected time off, or unemployment assistance. They also should include follow-up and check-in with cases and contacts periodically during their time in self-quarantine, assessing how well the contact is coping, reminding the service recipients to continue to self-monitor while staying at home. These steps not only advance justice, equity, and health literacy, but will help build and maintain public trust in public health efforts. Unfortunately, not many places are doing all of these, taking all of these steps. Few programs have adopted these holistic approaches. Massachusetts is one where they have adopted care resource coordinators in addition to offering the basics of contact tracing information and data gathering. They estimate that about 10 to 15% of the cases that they're seeing request these additional services from their coordinators, and it's likely that even more would benefit from such services. Quarantine, as far as the other component of this, besides the tracing itself, is the restriction of movement of the individual suspected of having been exposed to an infectious disease. Again, another ancient public health power, bounded by scientific standards, by due process and equal protection considerations, as well as ethical, civil, and human rights concerns. Participation under ethical best practices recommends that the least restrictive approach be used to bring about the desired public health outcome. Consequently, quarantine and isolation efforts tend to be presented as voluntary options. And because first and foremost, these are supposed to be preventive public health measures, not punitive. Unfortunately, what we're seeing is, and you can see from the a slew of different headlines, that any number of different challenges are obstructing the effectiveness of these interventions. For some populations, they cannot afford to stay home due to concerns about income, concerns about housing stability, concerns about childcare. And they may not be able to isolate themselves from their families or their loved ones. Those who are on campuses. One of the things that we're running into, I can talk about this during the Q&A. My daughter is in one of the Greek houses, 30 out of the 40 Greek houses on the Indiana University campus that have been quarantined. She's now living back here at our home and does not know when she's going to be allowed back onto campus in the midst of a semester. She's been asked to leave the campus and then has no idea about her return. Right now, we have not seen a lot of legal actions taken to try to enforce quarantine measures. But as you can see, some courts are getting ready. They're getting ramped up. I think this is going to be the next step in the process. I've got a number of other questions and concerns that are maybe arising. We can talk a little bit about travelers quarantine down the road, and the recommendations that are coming up. Those are available in my report, which you can get off the Public Health Law Watch website. If you have questions, I'm happy to take those at this point. And if you want to get back in touch with me, you can reach me at either the email address here or at the Twitter handle that you see on the screen. Thank you.
Great, we've had a few questions come in. Some states still have old quarantine laws on the books that require public health to place a sign in the quarantined individual's yard or on their front door notifying the public and the individual is under quarantine. What do you suspect that a court would say about these laws today?
I think what you would find in those circumstances, it may be difficult to challenge those under the emergent circumstances, but ethically, those are outdated standards. The ethical standards should be that you should be taking in and disclosing to the public the least restrictive or the least amount of information needed in order to address the public health concern. So in that particular kind of a circumstance, it's probably that's probably excessive by today's privacy standards, and should be reviewed and should be updated by the legislature to avoid unneeded stigma, as well as the potential for folks being more unwilling to get testing in case they themselves might end up having a sign on their lawn.
What are your thoughts about public health departments delegating all case investigation and contact tracing to a private entity, e.g. a university or another institution?
Well, I think the answer to that is, in part, it depends. It depends upon how well one of the things that we know with regard to infectious diseases is they pay no attention to boundaries. And so the blending or the blurring of the virus movement between a university setting and the community in which that university is set is going to be, it's going to be a negligible barrier. So information sharing in those circumstances between the public health agencies, sort of all of those under the cone of silence of privacy and confidentiality protection, that so long as it can be an aspect of a coordinated response, there may be benefits to having those systems because the community contact tracers are going to be closer to those who are being most affected. That said, within those structures, you would want to make sure that there are some understandings about baseline levels of the quality of the information that is being collected so that you can have a better understanding of the epidemiology of the disease.
Great, and this will be our last question. In addition to emergency actions like quarantine and mask mandates, has there been notable use of state police powers to address contributing issues like homelessness and access to healthcare?
That's an interesting question. One of the police power is something that is used more generally. It's kind of the fundamental power through which non-emergency actions are taken by public health departments. A lot of actions that, for example, issues that may be related to homelessness, issues that may, for example, the acquiring of hotels or changing around, which patients are going to go to which hospitals, or the setting up of field facilities. All of those different types of actions are largely going to be derived out of the responsibility of the state to protect the health, safety and welfare of its citizens.
Great, thank you. With that, we will turn it over to Jen. And Jen, are you on mute? There you
I
go.
was indeed. Thank you. Thank you all for being here. I repeat what Professor Silverman said. It's been an absolute privilege to be part of a project with such all-stars in the field. I also am not a very good lawyer, and therefore am not anybody's lawyer here. And you'll be shocked to hear that I also have no conflicts. No one is making any attempts to try to, sort of coerce me or do anything else. So this is largely based on my research and study, what other giants in the field have been saying, including Professor Silverman, who really laid the groundwork for me here today, and my own writings. So what I'm going to talk about today is privacy, surveillance, and I'm going to focus on digital contact tracing. And one of the reasons for this is because back in the day, back in March or April, everyone sort of started jumping up and down and said, one of the ways we can augment traditional contact tracing, which I'll talk about in a minute, is to use our technological forces in the United States to make this better. And we were even thinking that that might help us make up some ground that we had lost with inadequate testing and some other things where we were at a slow start compared to some of our neighbors in Asia and certainly Western Europe. And that has not occurred, but I do want to talk about to you a little background on traditional contact tracing. I don't think I need to spend much time on that because Professor Silverman has done a wonderful job covering that for me. The technology behind digital tracing, how health data privacy laws apply to digital contact tracing. And then at the end, I have my legal and policy recommendations, like I said, that were derived from any number of great works and other sources that folks did preceding me. And I have a list of those that we can chat about during the talk today, but they are also available in the COVID playbook in my chapter on surveillance, privacy, and apps. Okay, so traditional contact tracing, you can see here our plague doctor from medieval times. Professor Silverman's already talked about this. This is an age-old, ancient process, okay? Dates back to bubonic plague and syphilis outbreaks, in medieval Europe. No doubt about it. One of the things I want to emphasize to you, because I am going to talk about digital contact tracing, is that it is a time and resource intensive three-step process. And Professor Silverman talked about this. You've got to be able to identify infected individuals. So the precursor here, and I'm going to be somewhat repetitious on this, is that you have to have adequate testing in place in order for this to be successful on a grand scale, especially in a country, especially with this particular disease and its asymptomatic spread. Number two, you interview the individuals who are infected, have them quarantine, of course, get as much information as you can about their potential contacts, right? And then you reach out to those contacts. So it's an iterative process that requires constant contact with individuals, building trust, deriving a tremendous amount of very sensitive information about where someone's been over a 14-day period, as Professor Silverman told you, and interacting with folks in a way that reassures them and makes them feel like you're on their side, so they're very cooperative and are willing to share information with you. So that's the traditional process. Professor Silverman also told you this. It can be extremely effective in helping us to mitigate the spread of disease. Contact tracers who develop rapport with the folks that they talk to can encourage health-enhancing behaviors while they're doing these interviews and talking about next steps with folks, which is incredibly important in this process. Can help us in the United States, of course, reopen more quickly and safely, and therefore promote economic recovery, which a lot of people are obviously and rightfully very concerned about. And fourth, and certainly not least, protect the high-risk populations that are more likely to develop serious symptoms from viral contact and potentially even succumb to the disease. So he did a good job telling you about that. So there's some issues. Seema Shaw wrote a great book called Pandemic in 2016, and these are some quotes from her. She talks about how traditional contact tracing is very slow. As I said, it's time and resource intensive. It's passive. You're waiting till you get information or someone's already tested positive in an asymptomatic spread context like with SARS-CoV-2, and it's riddled with holes. And what she means when she says riddled with holes is that it relies on human memory and honesty. So you can imagine, Professor Silverman brought up the case of Massachusetts, and Massachusetts did something that was really incredible here. You have this long survey, and you're asking people all these questions, you're calling them on the phone, you've never met the person before. Some jurisdictions, some of the first questions on the survey after getting the preliminaries out of the way, like who are you and where do you live, or who did you sleep with last night and over the last 13 days. And as I'm sure you can imagine, for many people that might chill the conversation. I was just thinking back on this today when I went into class for the first time teaching at Seton Hall this year and said to the students, how are things going? What did you guys do this weekend? And the furtive glances were all over the place, right? And I wasn't even contact tracing. I wasn't looking or searching for information. People are very reticent to be judged. They're concerned that their behavior might be scrutinized. They're concerned that they might implicate other people. And of course, they want to protect their private associations. So you have to rely on human memory, which is very difficult to conjure up over 14 days. How many people did I stand by in the grocery store? How long was I in that line? Who all did I meet with? Who did I discuss things with? And then, of course, you have the honesty portion where people don't want to be judged or scrutinized. As I've said to you already, it's invasive and time-consuming. Massachusetts took a tack with its 251 public health departments of the preliminary questions that were asked, as Professor Silverman discussed, were, what can we do for you? How can we help you? If you need to isolate today, what sort of social services or assistance can we put in place that will make that possible for you? And of course, it's not possible for everyone. But some folks would say, look, I don't know how I'm going to get my groceries. I don't know how I'm going to pick up my medication for my grandmother. And Massachusetts was very responsive to that and built rapport by structuring their very long questionnaire in a way that built that kind of trust and rapport and offered assistance at the top of the questionnaire, as opposed to some other jurisdictions, like I said, that started out with incredibly invasive questions. Okay, it can be very effective, as we've already heard, but really you need these two things in place to have any chance here. Number one, accurate, widespread, and timely testing, which the United States has gotten a poor grade on across the board. It's very concerning how poorly we've done in this arena and continue to do. And two, public trust. You actually have to believe that the individual on the phone, you can trust them, you can share sensitive information with them, you can be candid and honest, and shake your memory, and that this information is not going to be used against you by the state or the police or EMS in the future if you need assistance. Okay, here's just a little classic example. I'm going to use my backyard, New Jersey. I'm sitting here in Hudson County, New Jersey, in Jersey City right now. We had a big outbreak at a 100+ party that involved 15 and 19-year-olds pretty recently here in New Jersey. You can see the headline. The contact tracers in Middletown, New Jersey really made an effort. They went out and tried to really nip this in the bud. Shortly after this party happened, there was upwards of 50 teenagers who had been infected with COVID, and they really wanted to put a stop to this. But they ran into obstacle after obstacle after obstacle. Number one, the teenagers were not responsive. They did not want their parents to know they had been at a party where there was alcohol, and other activities involved, okay, where they weren't supposed to be. Parents didn't want the state or anyone else to know that their children might have been doing something that could involve policing or criminal law or any other kind of sanction or getting punished at their school or implicate their college application. So it was incredibly difficult to get cooperation here in this case, and this was all over the New Jersey newspapers, and it ended up evolving into a really, really huge outbreak from this one very large party involving young teenagers. The other thing that was learned from this, lessons learned, is technology is not always what it's cracked up to be. These people, these students as a general rule from this upper middle class community in New Jersey did have smartphones and had smartphone access. However, they were very reluctant to answer phone calls. Teenagers don't generally engage in phone calls the way the rest of us might that are old like me. And it might have been a better approach to try to reach out to them by text or otherwise, because they don't even like to pick up the phone. So there was any number of problems here involving parents and teenagers and the attempt to nip this particular instance in the bud. And I thought I'd use an at-home case study for you, but this is going on, of course, all across the country in different ways. So digital contact tracing is going to come and save us now, right? We have all these issues. Google and Apple come up with their application protocols, right? Their application interface protocols for their devices, the Apple iPhones, right? And the Google Android phones, so that you can work across these platforms. And they did that very early on in April of 2020 to try to have something in place. And what the argument here was is this is way better than traditional contact tracing. You don't have to rely on human memory. The phone's going to handle the situation for you. All you have to do is have your smartphone on you. So we can be much more precise. We don't have to engage in nearly as many of these long interviews, etc. And we don't have to have as much public trust because the phone's going to pick this stuff up, right? So the argument is this is going to get us there a lot faster than building up this huge public health infrastructure and workforce. There was actually, to Professor Silverman's point earlier, there was a survey done by NPR in the middle of the summer, late July actually, and they, Johns Hopkins had said we need 100,000 contact tracers, and at that point the United States had stood up about 37,000 folks to do this work, so it was woefully inadequate. So this looks like it might come in to help us out and save us. All right. However, there are many cons of digital contact tracing, okay? The lack of widespread testing is perhaps the largest one. At least I thought it was important enough to put it down as my first bullet, because no contact tracing can work unless you have accurate, timely, and widespread testing going on so that you can identify things as early as possible in the front end and then start to isolate folks and reach out to their contacts, okay? That's still a huge problem in the United States. It's plagued us throughout the entire contagion. Number two, and this is a huge issue, this kind of technology really excludes people who don't have access to the latest smartphones. The APIs that were developed by Google and Apple really rely on the latest technology and even the latest versions of their phones, okay? A lot of folks don't have data plans that support this. They don't use these kind of phones, and that just really excludes a huge group of people who are at high risk for contracting the virus and, again, suffering debilitating health outcomes as a result. Digital contact tracing, of course, because it's following you around everywhere, it's learning a lot of things about your movements, it's learning a lot of things about your associations, raises even greater, right, privacy and civil rights concerns than traditional contact tracing, where you at least have some control over what you tell the contact tracer during the interview. And no matter how great digital contact tracing is, which is, like I said, not good in the United States right now, and I'll talk about that, it still needs to be augmented with traditional tracing for folks that cannot be reached or cannot access or don't have the financial means to use this technology or are reticent to do so. All right, so there's two versions of track and trace technology I'm going to talk to you about today: location applications, okay, and proximity applications. The location applications work like your GPS. They track your CSLI, which is your cell location information. You've got your cell phone on, it's off airplane mode, it's pinging to these satellites near you, and it's telling the system where you're at, okay? One of the problems with this is that it's highly invasive, okay? So these kinds of technologies can say, did you go into a particular church? Did you go and get plastic surgery? Did you go into a birth control clinic? Who are you associating with? Who are you having contacts with? Are you having underground political meetings? So this kind of technology is very concerning because it tracks all of your movements, all right? it's accurate enough to reveal these kinds of things, like you might have been in this very large building or this very large space or on this city block. But it's also highly inaccurate when we get to more and more rural communities because there's fewer and fewer satellites. So where in New York City, I might be able to track you down to like the individual city block or even building that you were in, I'm not going to be able to do that in rural North Dakota. Okay, I might be able to track you within the county, okay, or on a much larger, grandiose scale. So that is not going to tell me, or the contact tracers, which individual humans you've been within 6 feet of for 10 to 15 minutes. So it really falls down to the ground here. Very invasive, but not super helpful in lots of places about which people you've actually exposed yourself to for the requisite period of time for public health purposes. All right, so that's a big problem with this. So this is really disfavored. There's some case law in the United States that is very suspicious, including a case called Carpenter versus the United States, which was decided in 2018 by the United States Supreme Court, that cell site location data is really, really invasive, and the court is starting to protect that information, even under the Fourth Amendment, from law enforcement. So the more favored applications are these proximity applications. They use Bluetooth, low energy, that's being emitted from your phone. That only works in a small area, so we're not worried as much. It doesn't track your actual location on planet Earth like the cell site location does. Instead, what it does is it tells you how close you've been to another human being that also has a phone and for how long. And the phone logs those contacts. So Professor Silverman and I were having a conversation, and we were within 6 feet of one another. We both had our cell phones on each other. At the 15-minute mark, at the minimum, our phones would log that contact. And if he came back and tested positive for COVID, and we were in the same database in the same system, I would get some kind of an alert. It might not tell me that it's him, but it might tell me that I need to go get a test, or I need to isolate myself until I do, because I have a potential infectious contact. All right, that's how this works. It's preferred on privacy and effectiveness grounds because it's really worried about those intimate contacts. But there's a lot of variation and a lot of problems with even Bluetooth technology. First of all, the technology cannot distinguish between, let's say, I'm wearing all this PPE and I'm doing surgery and I'm close to a person and that person testing positive. It can't distinguish between you and your phone are separated by walls or other large structures, which would way reduce your risk. It can't distinguish between whether we're sitting by each other on the couch smooching, or we're in cars driving parallel on a major highway, which is of course incredibly much more safe and highly unlikely to risk transmission. So you're going to be, it's over-inclusive, right? It's also dramatically under-inclusive. While that Bluetooth's running on your phone, it's wearing that battery down on the phone. Okay, so people are going to be inclined to turn it off in order to use their phone for all the other purposes we use our phones for now. Also, you have to have that phone on your person. You can't sit it down at the front door over at the table 20 feet away and get the same result, even if you are sitting by the person. So it's dramatically over-inclusive. It's also under-inclusive. And as we've already discussed, there's plenty of people that either won't have their phone with them, won't have it on their person, or don't have a smartphone and a digital plan that works with this technology at all. So all of this stuff has its limitations once you sort of drill down on it. All right, so I just told you all this kind of stuff. Professor Silverman is right. He said sort of, even if you don't have widespread adoption, it's important. One of the things that we like to say is every contact traced is the potential to save a life. But in order for it to be super effective, you do need a concerted percentage of the population using this technology to be alerting each other, right? So it says 80% of smartphone app users is what's estimated, or about 6% of the overall population. So we would have to build that amount of public trust. That's nowhere in place right now in the United States. I've talked to you already about the over-inclusivity and the under-inclusivity issues. All right. So prevalence, numerous countries use this very successfully and relied on it very heavily. Singapore is often used as a classic example. They had a track and trace program that they put in place immediately that was handled by a government level public health entity that looked at this data. Taiwan, India, Australia, and Germany, and Italy have also been lauded for using this. Germany is a particularly interesting example because it has actually really ramped up traditional contact tracing to supplement the digital contact tracing that they're doing there. And so it's a very hybrid example that's very interesting. MIT, if you're interested in this issue, has a digital contract application tracker that they update all the time. You can go to their website and see what's going on. It's very interesting. As of to date, there's only 4 states that have actually indicated that they are putting in place or intend to use the Google Apple APIs. And so in the United States right now, as of today, we are largely relying on a fragmented and understaffed traditional contact tracing system and a country where we do not have timely and widespread testing going on, and have not built the sort of public trust that you see in some of these other countries that have had contagious disease outbreaks recently in the past, particularly in East Asia, that very much want, the culture is very cooperative on this, so that folks don't have to go through the things that they've been through recently on SARS and MERS, etc. All right, real quick here, we'll do the US data privacy laws. Professor Silverman went through this, so I don't need to spend a lot of time on it. Okay, so the backbone of this is the state's 10th Amendment police powers. They're not unlimited. I'll talk about that in the next slide. The federal government's role here, of course, is to supplement the state's authority through the tax and spend powers, Commerce Clause powers, by providing resources to the state. These kinds of things have not worked well in the current system, particularly with the federal government not enacting its full panoply of powers and resources to assist states with PPE, contact tracing, and all sorts of other interventions. Professor Silverman touched on this as well. The police power is not unlimited. You have all sorts of claims that you can bring. The most important thing here is reasonableness, proportionality, a real public health threat, and you don't harm any individuals, right, more than they will be harmed by not using the technology or going through the process here. And that it's fair, it's equally applied, it's not racist, it's not sexist. These are the sort of criteria that the courts tend to look at when they're evaluating the constitutionality of contact tracing. Again, it would be very difficult to raise a legal challenge to this in the context of a widespread contagion with asymptomatic spread, but I do want to emphasize that there are limits, and there are all sorts of ways these things could be deployed that would raise really serious constitutional concerns. Okay, constitutional privacy law. Not super helpful here. One area is this famous case of Whalen versus Doe that dealt with prescription drug monitoring programs in 1977. That case is often referred to by public health scholars as sort of the court acknowledging that we do have an implicit right to informational privacy. The courts have also acknowledged this in the healthcare context. Ferguson versus City of Charleston involved a public hospital in South Carolina collecting information on pregnant women by conducting surreptitious tests on them and then transferring that information to the police. It was a drug test, actually. That was struck down in 2001 by the Supreme Court under the 4th Amendment, saying you have a reasonable expectation of privacy and health data. I've already touched on some of these other cases. There's gross exceptions to this kind of stuff, particularly around border searches, folks coming in and out of the country, and folks who have transferred their information to other parties and consented, therefore, to the use of their healthcare privacy data. All right, the biggest misnomer here is a statute called HIPAA, which you just saw me put up on the screen, okay? HIPAA, you can see, is so widely misunderstood that it has developed a following on Twitter. Bad HIPAA takes, it's not HIPAA, it's HIPAA. People grossly misunderstand this. Due to HIPAA and the 4th Amendment, we cannot legally ask you about your medical condition. And there's any number of tweets here that HIPAA is going to save you. So let me just get this up real quick so I can take some questions here. Excuse me, I went too fast there. Sorry about that. So that's my bad. And now, apologize about that. Okay, so the point here, I don't know if people can still see my slides, is that HIPAA has 2 rules, a privacy and security rule, that are implicated here. But they only cover traditional healthcare entities and the traditional healthcare payer system. Okay, so they don't, HIPAA does not, as a general rule, apply to employers that are not involved in the healthcare process. They do not generally apply to like state agencies, and they do not apply to like universities or other privacy laws that may be implicated. Okay, so they're limited to healthcare providers, healthcare plans, and clearinghouses, and folks who do the healthcare related business called business associates with those individuals. Also, HIPAA only protects protected health information, which is health information that can identify an individual. So aggregate health data that takes your address and social security number and name and other identifiers out can still be collected by even covered entities under HIPAA. All right. HIPAA also has a bunch of exceptions, including law enforcement exceptions and exceptions for public health emergencies. So even a covered entity that was collecting protected health information could be protected in this context. Does not provide a private right of action, so you cannot vindicate your own HIPAA rights. You have to depend on the Office of Civil Rights at the Department of Health and Human Services to do that for you. So HIPAA is notoriously unhelpful here. There are some state laws that are much more protective, including the California Consumer Privacy Act here, that could be applicable to some of this data collected by third-party providers. That does provide a private right to action and allows you the right to vindicate yourself, correct your data, and delete your data. But that is not the case under the Federal Privacy Act. I'll end with this, and then my legal recommendations are in the slide and as well on in the book chapter. There have been 3 acts introduced in the United States Congress since the crisis started, all from April to June, and one is called the Exposure Notification Privacy Act, and I recommend you take a look at that. It was introduced on June 1st, and it does about 70% of what the recommendations are here that are included in the book. You know, it says you can't use this data for commercial purposes. You've got to delete it regularly. Individual users can ask to opt out. It's not mandatory, it's voluntary, but it doesn't include a private right of the action, and it has several other shortcomings that I discussed in the chapter. I'm going to stop, Neil, and take the Q&A.
Great. So the first question is, can you repeat the name of a case regarding privacy location applications?
Can I repeat the name of the case? No, there is a case called Carpenter versus the United States, which was decided in the United States Supreme Court in June of 2018. That case is about whether the police could use your cell site location data to pin your location down to implicate you in a crime. Timothy Carpenter had been accused of assisting in burglaries across the Midwest at Radio Shack and other stores, and the court said, no, that goes too far, it's too invasive, you cannot track that data for more than 7 days and collect it, and then without probable cause, without going to court, without getting a warrant, and then of course charge somebody with a crime for that. So my point about bringing up Carpenter was, in the cell site location arena, it's not only disfavored because I told you it's the shortcomings of the technology standing alone. The United States Supreme Court has a string of cases over the last 4 or 5 years that are very protective of information stored on smartphones. And they went so far in 2018 to say that this cell site location data, using these pings off of satellites, so the police can see what your location is over they actually collected information on him over about 150 plus days. They said more than 7 days of that is constitutionally questionable, and they ended up saying that the police were wrong not to have obtained a warrant and had probable cause before they were able to access that information from Timothy Carpenter's cell phone providers. And that case would be very relevant here if, let's say, you had a state agency attempting to collect that same kind of information for contact tracing purposes.
Thank you. Can you clarify whether proximity tracking Bluetooth technology records conversation or just identifies the person who presumably also has Bluetooth?
Right. No, there's none of these apps that I have ever seen record conversation at all. The Bluetooth is it's a little energy. It's this low light emission energy, and all it's doing is that the weight of those waves, the Bluetooth waves, is saying how close you are to another human, actually really to their phone, and the phones are sending these waves to one another. They're not collecting any other information as far as I know. The problem on the end of the Bluetooth situation is, what other information do you have to put into the app before you're using it, right? Do you have to put in your home address? Do you have to put in your social security number? Do you have to put in a whole bunch of other information? And does the state entity collect all of that up in a database? Singapore's trace and track system collected a ton of information, even though it used Bluetooth technology. It still collected a ton of information for people into a central healthcare database, and that was concerning for some folks. Google and Apple's view of this is that it's a public central database that only uses unique identifiers on your phone. So what would go up is your unique identifier, Professor Silverman's unique identifier, Anna's unique identifier, and if one of us triggered the app with a contact, the rest of us who had been in proximity with that individual based on our cell phone waves would be alerted and told to isolate and get a test, and potentially then thereafter be contacted by a contact tracer. So no, none of this technology that I've seen, even in the most centralized sort of authoritarian versions of this that involve a lot of state action, none of them involve collecting conversations.
Great, thank you. That concludes today's session. Please press the button underneath this video feed in Pathable, not the Zoom app, but the Pathable website to take the evaluation for this session. Thank you for attending and have a great rest of your day.